Hello, I'm Dr. Cora Sternberg, and on behalf of CME Outfitters, I'd like to welcome you to one of four of a CMEO podcasts in the series Castration-Sensitive Prostate Cancer, Navigating the Current Diagnostic and Treatment Landscape. Today we're going to talk about treatment options and clinical dilemmas in biochemical recurrence of prostate cancer. This is supported by an educational grant from Astellas and Pfizer. I'm Dr. Cora Sternberg. I'm the clinical director of the Englander Institute for Precision Medicine, professor of medicine, and Sandra at the Sandra and Edward Meyer Cancer Center at Weill Cornell Medicine in New York, New York. And I'm very fortunate today to be joined by my colleague, Dr. Peter Carroll, who's the Dana Der Chevron Distinguished Professor and the Taub Family Distinguished Professor in Urology in the Department of Urology at University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco. The learning objectives today are first, we're going to discuss stratifying patients with early prostate cancer for the risk of progression based on pathological, molecular, and clinical findings. And we're going to identify optimal treatment strategies in the management of patients with prostate cancer experiencing biochemical recurrence. Peter, I'm so happy to have you here today. We are colleagues for a long time. We both worked at Memorial Sloan Kettering together. So biochemically recurrent prostate cancer is an increasingly common disease state. With the increasing use of radical prostatectomy for the treatment of high-risk localized disease, this is something we see very often with PSA values that are very, very low as they're monitored carefully. Adjuvant radiotherapy is underutilized. It usually occurs in less than 10% of eligible men. And we know that there is a survival advantage to this, and there's support for adjuvant radiotherapy from several different associations, and we will discuss that a little bit later. Peter, I'd like you to talk a little bit about anticipating risk of biochemical recurrence at the time of diagnosis.
Cora, thanks for having me. Yes, there's several risk assessment strategies for prostate cancer. The common one used is the NCCN, or National Comprehensive Cancer Center Network's algorithm, and it puts people into very low, intermediate, high risk, and very high risk features depending on variables. The problem with this, it works very well for low and very low risk disease, but for men intermediate and high risk, I don't think it does quite as good a job as separating patients within those groups, because they can either have one or multiple variables. So I would recommend that a multivariable instrument be used when you're trying to predict for outcome, whether it be from radiation therapy or from surgery.
I know you've worked quite a lot on the UCSF, the CAPRA algorithm. Can you go through this with us a little bit?
Yeah, the UCSF CAPRA score is actually a multivariable risk instrument. You don't need a pen and pencil. You don't need a nomogram. It's a simple 0 through 10 score, validated in tens of thousands of patients around the world, predicts for biochemical recurrence after surgery or radiation, and also predicts for prostate cancer and overall survival. And it's just simply age, PSA at diagnosis, Gleason score, clinical stage, and percent positive biopsy cores. And I think this instrument predicts very well, and you can see that in intermediate and high risk disease, you get, I think, a much more refined estimate of outcome. I'd also want to point out to people that a high-risk patient shouldn't dissuade you from offering definitive therapy, because these are the patients who most benefit from aggressive local therapy. So even a patient who's at high risk for recurrence should get the option of having radiation or surgery done.
This was first developed with looking at radical prostatectomy specimens, correct? And then looked at radiation therapy specimens as well?
Correct.
Oh, I recalled that when you were developing that. So maybe we can talk a little bit about imaging and all of this. There's really quite a lot to be said. Most recently, a lot to be said about PSMA imaging, which has just recently been approved. What are your feelings about that?
So I think now the biggest advances in the diagnosis and staging of prostate cancer have been through the use of multiparametric MRI and currently PSMA-PET scan. And now we have, as you just stated, we have two scanning techniques, gallium-68 and PYL PSMA-PET, that have been approved by the FDA for the use in patients at high risk before treatment at the time of diagnosis, and those men who fail by PSA after radiation or surgery. I think these are the game changers. Increasingly, we'll rely on these scans, and I think the use of conventional CT, a bone scan, and other forms of PET will go by the wayside.
I agree with you completely. I mean, I'm working at Cornell, and we've had access to gallium PSMA, but the PYL that was just approved recently in May, I think will be a big game changer and should be available, I think, probably in the fall of 2021. And I think it will make a big difference for us in deciding about surgery, radiation therapy, adjuvant therapy after patients with biochemical relapse. Conventional CT and bone scans will probably fall by the wayside. I think you agree with that, don't you?
I agree. PSMA-PET has given us tremendous insight in the natural history of this disease, and we see patterns of outcome that we just simply didn't know existed before. And I think we're seeing a real opportunity to intervene earlier in those with advanced disease. Whether or not this impacts outcome is a topic of randomized trials currently underway.
Of course. Do you want to say something about oligometastatic disease?
Well, what I think oligometastatic disease, what I'd like to point out is this is a disease state we just didn't know existed before because we didn't have the imaging techniques that allowed us to detect it. So whether at the time of diagnosis or the time of failure, we identify patients who may not have widespread metastatic disease, but have pockets of disease either locally, regionally, and in some cases distantly that we did not know existed before. And I think now gives us the opportunity to test the hypothesis that aggressive local therapy and systematic therapy may have value. In the absence of just hormonal therapy alone, I think we're seeing an increasing use of both surgery and radiation in those who have either regional or limited metastatic disease.
Absolutely. I think this has been defined, however, with conventional scans, oligometastatic disease of less than or equal to 5 detectable metastases. I don't know if we'll want to redefine things once we have more widespread use of PSMA-PET. How do you feel about that?
Well, I agree completely. I think we need to have better predictors of such disease. When is a PSMA-PET most likely to be sensitive? We'll get into that. And I agree completely on what represents oligometastatic disease is all over the map and has been defined by conventional imaging. And also, how many detectable lesions constitutes oligometastatic disease is still a matter of some debate.
Yeah, but I think we definitely are curing or really making patients live longer. If we do find some small areas of oligometastatic disease, we're able to radiate them and then also treat them locally. So I think that this is a game changer, and there's a lot to be learned about this too. I definitely agree with you. So this, what about biochemical recurrence? We know it's a spectrum of disease after prior therapy, be it surgery or radiation. Do you want to say anything about that?
Well, I just want to point out that the biochemical recurrence definitions after surgery and radiation therapy are quite different. So with surgery, it's a detectable PSA of 0.2, and for radiation, it's a nadir PSA plus 2. These are not interchangeable, where the radiation definition actually predicts for clinical recurrence. The surgery definition is any recurrence. And of course, the surgery definition of 0.2 is confounded now by the increasing use of hypersensitive PSA tests that go down to 0.01, which predate the detection of a cut point of 0.2 by 12 to 24 months. So these are not interchangeable. We can use them, but I think we're going to need to come up with better operational definitions that we can apply across the board.
And we'll probably be using more and more PSMA-PETs and MRI scans probably to look for patients, particularly after surgery or radiation, to understand what we should do, with these patients. If we find a disease outside of the pelvis, for example, we want to radiate, we'll know where to radiate, whether or not to radiate the nodes, or the length of ADT, for example, can be influenced by this. Do you want to talk about the Capra score?
Well, what I point out here is when you have you can predict the risk of recurrence based on Capra and also Capra-S when you've done surgery, you have more things you can look like positive margins. But what I tell people is you can determine the actual risk of disease progression and the site of progression to some extent by what the primary tumor was at the time of diagnosis, time to biochemical recurrence, and PSA kinetics. So those who have an immediately detectable PSA after surgery, or those who have PSA doubling times less than 6 months, these are patients at risk for regional and metastatic relapse, whereas those who have a positive margin, late relapse, favorable kinetics are most likely to have clinical recurrence after surgery or radiation therapy, localized recurrence.
Are your treatment decisions based on what?
Well, they're based on the clinical characteristics, pathologic characteristics, but of course on the patient themselves, life expectancy, comorbidities, age, and preferences. Not all men who fail biochemically need treatment. There are some who have very favorable kinetics, advanced age, where in fact the morbidity of additional treatment may not be of value. But I think this comes into account no matter how we're counseling patients at any stage of disease.
Absolutely. So there have been studies looking at adjuvant versus salvage radiotherapy for biochemical recurrence. Do you want to talk about that a minute?
Well, as you mentioned, there are several societies recommended adjuvant radiation therapy be considered after surgery in men with higher risk features, but its use has actually been quite low, and we've demonstrated this over the years, and actually it's gotten a little bit lower more recently compared to previously. We have 3 randomized trials now which compared adjuvant versus salvage radiotherapy, and there was really no impact on overall outcome, and the radiation did have an increased risk of genitourinary side effects. So these trials suggested that, in fact, salvage radiotherapy is the current operational standard for urologists, radiation oncologists, and medical oncologists. But I want to point out in these 3 trials that most of the patients had lower risk disease. So there weren't a lot of high-risk patients in these 3 trials, and we've pointed that out recently now in 2 publications.
So patients who have node-positive disease, for instance, are not heavily in this trial. Patients with extracapsular extension are not so much represented in these trials. That's the major problem, right?
Correct, yeah. So these didn't have a lot of high-grade tumors, T3B or N-positive tumors. Again, positive margins, T3A cancers. These are lower-risk patients who have a lower risk of relapse.
But I think that a lot of physicians have taken away from these trials the fact that they can wait and they don't necessarily have to radiate and give adjuvant therapy. Would you agree with that?
I think it's generally true, but I think the word on high-risk patients is still not properly addressed. There are some high-risk patients who might benefit from early adjuvant radiation therapy, and they should be counseled about that option.
Absolutely. You want to talk about about the adjuvant radiotherapy is associated with lower all-cause mortality?
This is a big study that we participated in, led by Anthony D'Amico. It's a worldwide group of people put their data sources together on this. And this suggested, as you can see in the last panel to the right there, that low-risk patients, there was no benefit in all-cause mortality whether you gave adjuvant or salvage radiation therapy. But in the 2 panels to the left, you can see that men with node-positive disease and adverse pathology in the absence of node-positive disease appeared to benefit from the use of adjuvant radiation therapy. Now, again, this is not a randomized trial, but at least gives us pause to suggest that there are some high-risk patients who may benefit from adjuvant radiation therapy after surgery, and they should be counseled about that option. And these are patients with at least an 8 through 10 T3, T4 disease.
So this is really extremely important, even though we have the other 3 randomized trials, and they're mostly in patients with low-risk disease, like we see in the right-hand panel, the last panel. The other patients perhaps can benefit from the adjuvant radiotherapy.
Correct.
Yeah. What about, are you using PSMA for localizing recurrent disease in patients when you decide upon radiotherapy?
Well, we have heavily utilized it, and remember, FDA approval was granted to UCSF and UCLA for gallium-68 PET based on a large series done here at UCLA. And what it shows is site of disease you can identify, and again, I'm showing you here the PSA cut points and the sensitivity. So for a PSA of less than 0.5, sensitivity is about 38, 40%. As you increase PSA, the sensitive PSMA-PET becomes much, much better. Local recurrence actually for at UCSF is actually not common. Only about 15 to 20% of patients that we saw at UCSF or UCLA after surgery actually had local recurrence. The majority had either regional disease, pelvic or pelvic retroperitoneal disease. Bone disease, there in gray, was uncommon. So most people had regional plus retroperitoneal or regional alone. The important thing here, actually, it's been increasingly clear that you will change your management decisions between 50 and 40% of the time based on PSMA-PET. So PSMA-PET will give you more information. Now, whether or not that impacts overall outcome is unknown. But in fact, radiation therapists, medical oncologists, and urologists will change their treatment decisions based on PSMA-PET in a substantial number of cases.
Change their radiation fields, and they'll change the length of the androgen deprivation therapy, is what we're talking about,
correct.
Right? Based on this.
About 40% of the nodes identified on PSMA-PET are outside the standard fields for both surgery or radiation therapy. Pararectal nodes, presacral nodes. These are just not seen before, so both radiation and surgery didn't address disease in those sites.
And what do you do when you see pararectal nodes, as an idea? To give treatment, or do you still radiate?
No, we would. So we've taken a rather aggressive stance, and in cases we would address those either at the time of surgery or the time of radiation therapy. We're actually using now. We have a new phase 1 study on a PSMA fluorophore, which allows us to identify the disease at the time of surgery. But we would either radiate if the patient's candidate for radiation therapy. If they're candidate for surgery, we would try and remove those lymph nodes.
But if the patient has a biochemical recurrence after radical prostatectomy, and you find a perirectal node, and you're planning radiation therapy, would you still do the radiation therapy anyway, or would you think of that as a patient more for systemic therapy?
We would do both.
Yeah, we do the same at Cornell too. I don't know if it's general practice, but that's what we're doing as well. Here we're talking a little bit about PSMA-PET and how important it can be in changing our treatment strategy. Do you want to go through this?
Well, it points out that I think not all men need treatment. I think that I have a patient I saw recently who had surgery somewhere else, failed, had radiation and hormonal therapy, failed, and has actually very favorable PSA kinetics currently. Doubling time beyond 12 months. Patients of advanced age, PSMA-PET negative, we're going to follow that patient. We'll discuss intermittent hormonal therapy or systemic therapy if, in fact, disease characteristics change. If you identify local recurrence only, I think that will give you a chance for local radiation or surgery if the patient had previous radiation or focal ablation. We move towards systemic therapy in those with advanced disease, but again, increasingly now, since we're identifying patients with a limited volume of either regional retroperitoneal or metastatic disease, we're seeing more combination therapy be done. Combination of hormonal therapy and systemic therapy. So radiation, hormonal therapy, abiraterone. So we've taken a more aggressive approach to these patients, and I think time will tell whether or not we have an impact on outcome, which is favorable. But the early results suggest that there may be a favorable outcome when you treat patients with limited metastatic disease with combination treatment.
And also with perhaps radiation to the oligometastatic sites as well, in addition to
Correct.
what you said. Yeah. So do you want to talk about the Porto study and the 24 gene signature?
Yeah, I just want to point out that the genomic profiling complements imaging. So in the last decade, we've seen this emergence of both molecular imaging and genomic testing. And I think they both have advanced the field significantly. I just want to point out that genomic signatures can predict postoperative outcomes. So the Decipher score, or in Decipher Grid, Porto, so 24 gene signature, which predicts postoperative radiation outcomes. We frequently use those. And histology, the PAM50, again, popularized in breast cancer, has shown to be of value in those with prostate cancer, and some luminal subtypes of those which are more likely to respond to hormonal therapy. So again, these are predictive signatures, and there'll be more coming out. But it just suggests that you will use genomic profiling in combination with molecular imaging to give you a more refined approach to treatment.
I think that, we're evaluating in study Decipher score, for example, to decide, what the length of radiation, the length of hormonal therapy that we should be giving, and also the fields of radiation as well, to understand how high risk the patients really are. Do you want to talk about anything, the difference between PORTOS and Decipher?
Well, the Decipher is the standard 22 gene commercial signature. But if you order the Decipher grid, you'll get the PORTOS signature. So again, they're both variations in the theme. They're both genetic profiles which allow you to determine the need or the risk of recurrence. So remember, Decipher is a prognostic biomarker. It tells you what the risk of recurrence is, where PORTOS is a predictive biomarker. It tells you what the outcome will be. So I think they're complementary. But there'll be more coming. There's a lot of work in this area, and we're seeing more emphasis on predictive biomarkers to actually guide you to select one form of treatment or another, or the length of treatment.
The length of treatment, absolutely. So I want to thank you very, very much, Peter. You gave a very nice overview for everyone. And I just want to conclude by saying that it's really important that we incorporate risk assessment algorithms into our routine use, that we utilize advanced imaging to detect sites and extent of disease and biochemical recurrence to guide our treatment choices. We really should be considering the use of genomic profiling to assess the risk to guide our treatments, and I think you'll see this being increasingly used. And you must consider adjuvant radiotherapy in the men with adverse pathology after radical prostatectomy. I'd like to thank you very much, Peter, for this very interesting discussion, and thank all of you for your participation. To receive CME credits, please click on the link to complete the online post-test and evaluation. And I also want to remind the audience that this is one podcast in a series of 4, and I hope you listen to the entire series. Thank you again for joining us today, and thank you for your care of patients. Thank you very much, Peter. It was great to see you.
Cor, thank you.